Thank you, Senior. As Senior said, today we are going to learn about subcutaneous infusion. We all familiar with subcutaneous injections, but we are not familiar with subcutaneous infusions. Today we have Swarup with us. We last 2 weeks back he took a session. We all know him. I don't think to introduce again. Swarup, welcome back and over to you.
Thank you, Shiv. Thank you so much. So very good afternoon to everybody. I hope you're having a very good time. Very nice to see you again. We'll start our discussion now. The Tipseco is going to share the screen for me. Thank you for helping me in that. Thank you so much. Thank you. So once again, a very good afternoon to everybody. I hope this session is going to give you a little bit more information about what the subcutaneous infusion, and there are a few things what we have to learn in the given time, like what exactly in palliative care are we going to do with this infusions. So you can try to mute your phones so that it will not be more disturbing to the others. So please think about that. Yeah, next slide, please. Thank you. So we'll start with the case discussion. So every time when you have a case in front of you, before you start discussing about any topic or any kind of education to your team, I feel that there should be a kind of a case history which gives you a bit of information, and there should be a question raised for every one of us before we start the session. So at the end of the session, there should be approved answer, or what is the achievement if you are going to do with this. So that's the reason why I put the case history before I start my session. So there is a patient named X and diagnosed with the carcinoma of the right breast with the infected wound and lung metastasis. I'm not just discussing only about subcutaneous infusion, but I'm going to add some more points to that, where exactly the subcutaneous infusion or the injections is more compatible or more related to that patient. So we'll see about the case history. The patient named X and the diagnosis with the carcinoma of the right breast with infected wound, and also she developed the lung metastasis. The disease from the breast has spread to the lungs even, and her performance, like palliative performance score, is 20%, and she is experiencing severe pain in the chest, breathlessness, as well as anxious too. So in the first point itself, we have got a lot of information about the patient present status. These are all the physical issues, we can say. And coming back to the family background, the financial and the family background, they are from a very poor, their economy is very poor, family background, and they reside in a remote area. Just keep something in mind whenever you treat the patients. You have to think about how their financial status is. You have to think about how the house looks like. When you have a very good expected or good centers in your places, like you having an alpha bed or air bed followed by a good ICU setup, even though forget about it, because when the patient is been getting discharged from the hospital, there are a few things which you have to keep it in mind. These patients doesn't have any kind of such equipments or to be placed at home. So just try to think about how the condition of the place is. And third point is, how can we help this patient and family in their suffering? So every patient, you should think about, how am I going to help this patient? When you start thinking about what is my role, and try to reflect the cases to you. When you start thinking about the case, that case should reflect to you. This reflection is nothing but wherever there are some faults or the failures happening, you can easily try to modify that or change such things. Or there is something which you have to learn, you can learn and implement it in your centers to those patients. So overall, the goal of action should be comfort care and providing providing a good quality for the patient and also the dignity during the death of the patient. So how can we help the patient and their family members? I'm not just adding the patient himself, but also the family, because family plays a major role in all the scenarios, because they are the decision makers. They are the one who have to bear the financial burden, and they are the one who has to judge it. They are the one who has to bear everything. So it's important not just the patient, to also involve the family in every kind of discussions, whatever you do. Even if you change the medications, it has to be informed to the family. If you are planning some kind of sedation to the patient, it has to be discussed with the family. Those kind of information sharing will really help the patient as well as the family in providing your care to them. So how do you provide a good quality care and comfort during her end of life? So last three questions will be, should be reflected to every one of us. Each and every one of us who have joined here are really having a lot of enthusiasm, nor the patients who are suffering a lot were been treated by you one day. So when you go back and start your palliative care centers, you have to think about how exactly am I going to deal with this patient? What would be my care plan? See, when you have a good care plan, or when you start thinking about the patient before you start your work, it gives you a lot of information, or you will be prepared of what exactly am I going to do. When you have such information in your mind, that makes your work more easier and flexible. If you don't have such things in your mind, what is going to happen is you are not planned, so the things may change. The patient performance is very poor. The patient could not take any kind of oral medications, nor the patient is in a state where he couldn't take anything orally, and the family is trying to forcefully feed the patient, and the patient is developing cough. Just think about it. When you don't talk, the whole burden will be on the nurse's side. So have this question in the mind and start our discussion today. Yeah. Among this, there are a few things which I would like to talk about. Those are, just a minute. Okay. Number one is a patient with the breast cancer, which means that this cancer is not going to be get cured. And she also had an infected wound with the lung metastasis. There are few things in that. And also the patient's performance is 20%. Palliative performance scale or the score, which is 20%, which means that there are the few categorized centers where you have to think about. Number one is the level of extensive disease. Number two, food intake. So extensive disease, this disease has spread to the lungs, might be to the bone, not to the brain. I'm not sure, but somewhere this is a spread extensive disease in the patient side. Number one. Number two, this patient cannot take any oral medications. That's the reason why we have put this patient into 20%. Number three, the patient level of consciousness or the drowsiness, sometimes it may increase or it may aggravate or may reduce. So he's not doing well, and decreased food intake. So based on all these categories, we have scored his performance as 20, which is nothing but the conscious levels are poor, the patient is not doing well, and the patient can't take anything orally. So the nurse really can plan a lot of things in that. Like, how do I deal with the feeding right now? The family is insisting for me to feed. How do I administer the medications? See, example, the same patient was in a very good state a week ago. Think about his performance is more than 50. 50 performance is nothing but the patient is conscious enough, he's able to walk around, he's taking medications on his own, he's active, and he's able to do his own works, activities of daily living, and also the disease is bit under control. Just think, assume that. And all of a sudden, the patient's performance has come down to 20, which means that you may have to change the pattern of using the medications. Like earlier, he was on oral medications. Now, the medication or the route has to be changed. And this patient is experiencing severe pain over the chest region and also is breathless and anxious. So we don't know exactly what is bothering the patient, but still, you should have a good care plan in your mind about how and what your goal is going to be. Next slide, please. Okay, so what is this subcutaneous infusion is all about? Why are we going to learn about that? We all, in our general practices, we have seen the IV routes, which is more safer, more easier, and flexibly used in every hospital. And intramuscular, we all know about that. There are a lot of other routes. Why are we choosing the subcutaneous infusions in the palliative care center? We have to think about it. So it is nothing but an alternative route of intravenous or intramuscular. It is a subcutaneous injection. So subcutaneous injection is administered as a bolus into into the skin directly, just beneath the dermis and epidermis. So it is also an highly effective administration of medication. Next slide, please. Okay, so this is a one way of administering or fixing the port directly under the skin. So as we have seen a little bit of information there, we are going to introduce directly underneath the skin below the dermis layer, and it remains in there. Yeah, next slide, please. I just wanted to show you, this is called as a butterfly needle. And here comes the 26 gauged IV cannula. So it is generally preferred for the IV cannulation, but also it is more safer for the subcutaneous route too. We'll talk more about that in detail, but just have a look at how it has been placed. So in other countries, I have seen there is a very large needle contained plastic tube inserted directly under the subcutaneous layer, and the needle will be taken out at last. So it just shows that it has gone more deeper into the area, and you could not see any kind of extravasation around. So it is more comfortable comparatively, and because of the needle comes back and will be disconnecting the needle, and only the plastic tubing just or the rubber tubing remains underneath the skin, and it is more helpful in comparatively to the butterfly needle. It is more comfortable. Only thing is the family has to be explained about what it is. Next slide, please. We'll talk more about that. Okay, so the drive fixed to the IV tubing. So you can see the green colored cloth covered with the infusion pump, and the IV tubing, the IV set connected over the syringe, and on the other end there is a needle placed in. So this end is going to be inserted directly into the IV cannula site. You just have to open the IV cannula site and then just fix it there and leave it open. So the drug can be continuously entered into that. We'll talk about that. Don't get confused into that. I just wanted to show you the pictures and then go back to the scenario. Next slide, please. Okay, this is how the infusion pump remains. There are few other infusion pumps which are portable and which can be connected directly to the power supply, or few can run directly with the battery. This is also one of a portable syringe drive which runs with the battery, and this can be fixed directly to the patient body, not just directly to the body. It can be placed over in the pouch with a connector, and it can remain on the patient's body for a while. So that means that this patient can move around or do his own works. So just have a look at the drugs which are mentioned on that. The drugs which are mentioned are written in the capital letters, like injection morphine. Just have a deep look at that. Can you just zoom in if possible? Is it possible for you to zoom in a little bit?
No, sir.
Not possible? That's fine. Okay, so there are some drugs which are mixed together. There are a few compatible drugs mixed together, like morphine. I'll just read out for you, and that is morphine 30 mg. Thank you so much. Okay, that is morphine 30 mg and midazolam 10 mg, that is 10 ml, and haloperidol 2 mg. So all these drugs together has been put or mixed together, and we started at particular point of time. Come back to the case scenario we discussed about. So that case, the patient is in a state where he couldn't take any medications orally. If the patient assume that the patient is on 10 mg of oral morphine, and maybe other drugs like lorazepam, haloperidol, and a lot of other drugs too. But if you feel that the patient performance is bad, which means that the patient cannot take any medications orally, and then the route has to be changed, which is nothing but the subcutaneous infusion route. So once you start using this infusion, which is parallel or an alternative route of administering the medications, do not delay, because the patient is already in pain. That's the reason why when he was conscious, he was put on the oral medications like morphine. And once, due to different situations, like the patient's performance has become poor and there is nothing we can change, but still there are few things like changing the route of administration is more important. Once you stop using morphine all of a suddenly, you have to see those withdrawal symptoms again to prevent, and also the patient will be very uncomfortable. In my earlier slide, what is my goal is going to be is nothing but provide a good quality care and the dignity during the death of the patient and the end of life, maybe at the end of life. So when you start thinking about that, it's important for you to have an alternative route. So the performance or the patient's activities is coming down day by day, which means that you and the family has to be prepared in facing that worst case scenario. So this patient is with, like I told you before, he is in a lot of pain and anxious and breathlessness. That's the reason why I have put morphine, the drug of choice for pain as well as breathlessness. Number one. Number two, the midazolam, very short-acting benzodiazepine. We have put this drug for reducing the anxiety as well as the breathlessness. Number three, the mixture of the morphine and the benzodiazepines sometimes may lead to a little bit of confusion. Nor the end of life confusion is most common, as we have discussed earlier about the performance 20, which means that the patient's level of consciousness comes down and the patients might become more drowsy, nor confused. So it is most common. It's a most common symptom in end of life. So which has to be addressed and modified or managed well. So we have also added haloperidol to them. The idea is all the drugs will be going together in controlling the symptoms of the patient. Yeah. Let's go to the next slide, please. Okay, so why are we choosing this subcutaneous injections? Because it can be given, it can be used to give many types of medications for various medical conditions. Like you see, morphine, very safer, very comfortable, and easily administered by, we'll talk about that. So various medical conditions like pain, breathlessness, nausea, vomiting, when the patient is having intractable vomitings, and you couldn't get any kind of IV accessibility at all. You have to take a choice in administering medications through the subcutaneous route. Why are we preferring that is many drugs which are used in palliative care can be given through that route, and it is more safer. It is most probably preferred for patients who cannot take oral medications for different reasons, like patient is having intractable vomitings. Assume that the patient is having more vomitings and IV accessibility is possible. But do you think the family can administer once the patient goes home? And it is more safer. Subcutaneous injections are more safer in patients who cannot take oral medications due to different reasons, or the patient might become semi-conscious. The same case, who cannot take any kind of oral medications. You might have different routes like transdermal patches are also available. Then how about the other drugs? There are a few other drugs which can't be given through that route. So, and also these are all not the fast acting. It is very slow acting and long lasts. Okay, it helps to have a continuous flow of medications to avoid delay. Just assume that most of our nurses are more busy in their works. Might be each nurse can handle approximately 6 patients. If the limit is crossed, automatically there will be a trouble for that nurse, and she'll be busy with one patient, and these patients who are about to administer morphine has been delayed for a while, and again all of a sudden the pain may go up down. It may change. Sometimes it might be fluctuating. It may be in that situation the pain may come back. So when there are patients who are with a lot of pain, uncontrolled pain, then you have to have a thought that what would be the choice of action to be. Instead, you frequently wasting our time sitting there and spending a lot of time in administering the medications, you can just do one single thing, just connect it to the subcutaneous infusion, leave it or run it for a while so that you'll have time to see other patients. So that's how it is more helpful for the nurses even. And also it is beneficial in avoiding the delays. Number 4, drugs which are with the 3 compatibility given can also be given through this route. So try to go through the drug formulary. We also have a 7th edition, I think so, 7 or 8, I'm not sure. So just go through this drug formulary, so you'll get the compatible drugs like morphine, midazolam, and haloperidol. This is just a 3 compatibility drugs because drugs are been divided into 2 different areas, like few are alkaline form and few are acidic form. So there are few neutral drugs even. Sometimes these alkaline and acidic drugs can't be mixed together, and there are drugs like oily preparations could not be mixed together. So somebody try to mute your phones, please. It's distracting on the other side, please. Yeah. So the drug compatibility has to be seen. For example, when you see morphine, and there are some other drugs like ketorolac, which is an NSAID, and it is in an alkaline form. So this morphine can't be mixed with the ketorolac, because when you go through this drug formulary, that gives you more information or drug compatibility. So whether these drugs are compatible or not. When the drugs are not compatible, the change in the color of the drugs will be visible in the loaded syringes, and also the the crystals might form in that. So which means that these drugs are not safer in administering in that way when it is in a damaged form or uncompatible form. When you administer those drugs just like that, you see the extra vegetation around the surface. So never go for that. Just look into, even you can just search on the Google about whether to use these drugs together or not, and then you can go for it. Next slide, please. Okay, so in which condition do you think the subcutaneous routes to be preferred? The patients who are experiencing intractable vomitings. The patient have a lot of vomitings. He is just spitting out all the time. Regurgitation, nor the patients who are in the end of life, nor any kind of subacute intestinal obstructions might develop more of vomiting. Sometimes I see patient with a lot of fecal vomitings even. So even such patients also can be managed with the subcutaneous route. So patients experiencing intractable vomitings, number one, the patients with the uncontrolled pain and could not tolerate oral medications. So one of the, just a minute, please. One of the important thing I would like to tell you, in my experience, when I've been to some other countries, like for example, I've been to Canada, where I have seen very good expert nurses. So all the units are nurse-run clinics. I saw even in the children pediatric palliative care unit, nor the adult palliative care units. So all the units are run by the nurses themselves. There was a patient who was with severe pain. The nurse herself, with all her experience, came forward, changed the medications from oral to the injectable route, because the oral route drugs are safer. But on the other side, when these drugs are not helpful, she has skipped up those medicines to the injectables. That is an IV route, not the subcutaneous route, which is called as a stacking principle. So she hasn't thought about that. So she just, sorry. Yeah, fine. Okay. So when the patient is having uncontrolled pain, she have preferred the subcutaneous route of injection morphine. So which is giving the patient more comfortable, and also the breakthrough doses to administer is also made more easier. This patient was administered for the whole night, and after 12 hours, the next morning, the patient was put back on oral morphine with the increased dose. The small change I have observed in them is, okay, when there is an incident or the pain which is not under control, not controlled with the oral medications, automatically the patient has been skipped up to the injectable form for a day under observation, and the patient was brought back to the oral medications. When you start doing such good principles, you see a lot of changes in the patients. With all the education or the information shared with the family and the patient that your pain is not under control, I wanted to change it to this route. You have an intractable vomiting, I wanted to change it through this route. Because many patients I see this kind of needles poking some other place apart from the IV intravenous, they just worry about, or they may just become tensed about this kind of new administration of medications. It is all not so familiar for us. Even for the first time, many of our people have been listening to that. So but still it is more safer, and it is helpful for many drugs to be administered through this route. So have this in mind. So whenever their patients are suffering a lot, you just have to inform them that I wanted to change it for a while. Overall, the goal or the concept is you're targeting the patient, and you are seeking for the comfort on the patient side. So surely the patient and the family will be supporting you in that situation. Third point is the semi-comatose state. The patients who are in a very bad state, to control the symptoms like pain, breathlessness, delirium, and nausea, vomiting, it is more helpful. Even in the semi-comatose state too, subcutaneous more preferable, and in controlling the symptoms and hydration, even in the lifeline. We prefer when the patient is in the end of life, but on the other side, we feel that the patient is dehydrated. If that is how the situation, go for the subcutaneous infusion, and also the hydration can also be given The 500 ml of infusion can be given approximately for more than 12 to 18 hours, very slow, regulate it well. And uncontrolled breathlessness, instead going for the oral route again. Oral route, already the patient is breathless, anxious and worried in the situation. He couldn't take any kind of oral medications. And so better go for the subcutaneous injections like morphine, compatible drugs like methadone, midazolam, can also be lorazepam, also can be given through that route. Once the patient's breathlessness is stabilized, come back to oral. So this gives you and the patient a lot of support from the palliative care unit. They feel that, okay, there are people who are thinking about me. There are people who can help me in that situations. And situations like, as I earlier told you about, the subcutaneous, subacute intestinal obstructions. Like maybe in that situations, patients develop fecal vomiting. Stool will not be passed through the rectum or through the anus, and due to the multiple obstructions in the intestine, the stool which is collected in the small intestine and the upper large intestine will be completely blocked, and the stool comes out through the mouth. So which is called as a fecal vomitings. Maybe in that situations, it's a worst case scenario to say. And even at that time, the subcutaneous route will be more helpful in administering the medications, the other medications. Next slide, please. So what are the benefits? Why are we doing this? What are the benefits associated with the pain management? Can be used in patients with the poor venous access. If you feel like many of our patients in our hospice, we run a 21-bedded adult hospice as well as 8-bedded pediatric palliative care hospice. So in all both the programs, also we have a home care setup too. We see a lot of such patients who undergo chemotherapy. Their veins are been damaged and become harder and thicker. You don't get any kind of accessibility for the vein. So repeated poking gives a lot of pain again. Just 1 minute, please. Okay, sir, charging better. Okay, so many times the poor accessibility of the veins is also one of major procedural pain related situations where patients experience a lot of pain just because of repeated poking into that area. They're fragile, they're an end of life, but still these pains may remain long till the death. So what would be the choice? Instead going for the IV, are there any other options for that? When you look into that, the subcutaneous is the best option. So when there is a poor venous access, you can go for that. So provides pain relief for patients who are unable to tolerate oral pain medications. For example, I have taken oral morphine just now. Half an hour passed, an hour passed, and still the patient's pain is not under control. You can't just go on giving oral medications again. The patients might lose hope on you, not your department, not the unit. There are many other hospitals who practice in that situation where they administer only oral medications. The patient's pain is severe, they don't mind whatever the patient is suffering it. They just look into their own aspect and write oral medications and they leave. You know, these patients will not return to the hospital again to see those doctors. Never say hi to them, except bye. They come back to the palliative care on their own, or with the spread of the word to the others or the neighbors somewhere. They come to the palliative care and request us to control the pain. So we can't just take a step on going for administering the medications orally again. We know that we administer morphine injectables as a morphine trail. So somewhere you have to think about how to control the problem, either the pain or other symptoms. As we are discussing in this slide about the pain, I'm talking more about that. Allows patients greater mobility. So once the symptoms are controlled, that will be more helpful for the patient. Assume that the patient is on bed all the day, as there is no controlled pain, and he couldn't tell you exactly. When you don't have a good assessment, you can't manage the patients well. When you have a proper management, it's easy for you to manage the symptoms, and also it doesn't stop with that. And also you have to have a very good follow-up care even. So yesterday I have treated this patient for the pain management, administering subcutaneous medications, and his pain was a bit controlled yesterday. What really did happen today? So you have to go or have a phone follow-up, think about, did the patient achieve with that, benefited with that, nor it is the same like yesterday. When you just have a good follow-up, that gives you a lot of information, and also it will be a good education for us too. That's nothing but a case reflection. So how did that reflect you? That's how we have to look into. So onset of action takes about 20 minutes. So even the subcutaneous infusion can be helpful, not like an IV, but takes a little bit of time to work on, but more comfortable and safer comparatively. So costs are almost half of those associated with the infusion, IV infusion. Yeah, next slide, please. So what are the things to watch for when the patient is on subcutaneous infusion? Number one, are we using a small gauged winged butterfly needle with a shorter length? Number one, do not go for the 22 gauged or 18 gauged bigger cannula, which we use it for the blood transfusion. Use a smaller one, even though we know that use a bigger gauge, it's of more pain. So to prevent that, use a smaller one, which is more safer and pain-free for the patient. The site selection depends on the patient activity levels and type of medications delivered. If you feel that there are a lot of infusions has to be given through, and then the abdomen is a better site, like both bilateral lumbar site is the most preferred site, and the small volumes of the injections also has to be given only when it is placed over the both sides of the chest or below the deltoid. Many of our patients are it's all the site preferred by the patient himself. Instead we deciding of what to do, just give an example of I wanted to insert this cannula for the subcutaneous medications. Where do you want that to be? Do you, sometimes the patients say that I wanted to see that every day. If that is how the situation, just go below the deltoid. It is more visible for sometimes even patients can open up and see that whether the site is safer or not. And sometimes patient doesn't want that to happen. If you see the lymphedema, bilateral lymphedema, go for the abdomen, nor the lateral aspect of a thigh. It's more preferable. And the site is preferred by the patient. And if the patient is in delirium state or the patient is confused, trying to pull out everything, whatever is on his body, either the IV cannula, the catheter, the Riles tube, nor the subcutaneous port, whatever it is, he's trying to remove out. So scapula is the best site. Both sides of the scapula is the best site to administer or fix the subcutaneous port. Port is nothing but the subcutaneous cannula is been fixed over that area. We call it as a IV cannulization, as the same IV port or the subcutaneous port. So port is nothing but something is placed for a period of time. That's nothing but the port. And the site, the avoid sites where the tubing of the pump could be disturbed. It should not be when you connect an infusion pump to the through the IV cannula or the subcutaneous port. It should be a lengthy tubing where the tube or the pump should not be disturbed in. So it should not be very close to the patient nor very far to the patient. It should be it should give some kind of comfort or so that the patient can turn on to the other side. So the site should be free from irritation and away from the bony prominences and waistline. Keep this in mind whenever you fix the port and look for any kind of changes happening, like a report for complications like leakage from the site, nor the redness and the discomfort at the injection site. If the patient feels a lot of pain or you see a lot of redness over that area, and you may have to change the port, which means that it is hurting him. And don't try to introduce a lot of drugs together. Just an 1 ml or 2 ml is more enough to that through that route in one push. So it should be administered very slowly and try to have a little volume instead of administering larger volumes into that. Next slide, please. Okay, so on subcutaneous hydration, when you are administering hydration like fluids, IV fluids through that route, watch for the local swelling and minimize the flow. So when you have to regulate the flow is nothing but from this IV cannula or the subcutaneous port, you look for huge swelling. When you see the huge swelling, which means that the flow is higher, you have to regulate it based on the swelling. You just have to regulate the flow of the fluid from the connected setup. Point number 2 is the patient and the family has to be explained about the route of administration, because many of our patients and family members are familiar with administering IV fluids. but they really don't know about the subcutaneous infusion. But you may have to talk about the benefits and the advantages and disadvantages and what it is going to be and how beneficial it is going to be. You have to talk about that. So check for the patient's response to the medications. When you start on some medications through that route, check for the response. When you start administering the pain medications, nor the patient medications for the vomiting, not the medications for breathlessness, not the delirium, whatever the problem is, scenario is, and by the evening have a look at that. When you go back home, look for the any changes happening there, the response from the patient side. To check the response, what we try to do is, if the patient is having a lot of pain, breathlessness, and irritable, we have a care plan. Every second hourly, our nurses used to go and assess the complaints and come back with the information that okay, the pain is still 8 by 10 in the morning, it is continued in the afternoon, sorry, it is continued the same in the night. So tomorrow morning when you come back, if you see the pain is still the same, if you see the patient's breathlessness is still continued as the same, so which means that the failure is on our part, not from the patient side, nor any other thing. Your assessment has gone bad, or your management would have not worked properly, which means that you don't have a much of education about whether to increase the doses of medications, nor you wanted to continue the same. So it gives you a lot of information about after looking to the patient's response to the medications. Check whether the device is working well or not. Sometimes the batteries might not work well, or it may get drained, or the power supply, are we connecting it in a proper way? You have to look into that. So check for any kind of precipitations or crystallizations in the syringes what you have loaded. When there is a compatibility, few uncompatible drugs mixed together, you can see a lot of precipitations in. And approximately through the subcutaneous port, the fluids given are approximately 1500 ml, can be administered from approximately to 16 hours to 24 hours, because it is just given as a lifeline. It is not going to help the patient to recover at all, but it is helpful in in bringing the family to showing them that, see, even though it is not going to be helpful, then why are we administering the fluids then? There should be a question for every one of us. It helps in controlling the dehydration, and if it is an end of life, we have to add those ethical principles and tell the family that even after administering the medications, the patient's performance is not picking up, which means that he's becoming more and more worse. There is nothing you can do. Next slide, please. There are few equipments required to fix up the port. Number one, at least clean gloves and the alcohol swabs to wipe up that area in a circular manner and leave it open for a while, and then it's easy for you to fix the port. Any kind of antibacterial skin preparations, and use a 26 gauged IV catheter, and medications in appropriate syringes or container. So whenever you load those medications, it has to be labeled well, and it should also contain the date, and labeled medication should be in a capital letter form, and whoever the nurse is loading it. And for example, injection morphine 1 ml is equal to 5 mg. That's how the note has to be on the syringe. And there should be a medication administration record. When are we starting that? Why are we giving these medications? Did the patient feel comfort after administering the medications or not? Did the patient achieve whatever it is? And did you achieve the goal? Did you control the pain? So this administration record helps in maintaining the good documentation, and also it gives you a little bit of information and the evidence in your research. Like I have administered morphine with the combination of midazolam for his pain and breathlessness, and the patient has achieved or not. If that is not achieved, go and check for the articles or journals which shows you a lot of information on how to manage the patient's pain and breathlessness, and then it is easy for you to put your own steps in for that. Yeah, next slide, please. So there are a few points to remember. Use infusion pump, whatever you have, for 12 hours to assess the symptoms. That is more helpful. So if you feel that the patient was put on morphine, the same case scenario I'm bringing back to you, the patient's performance is very poor, but still there are few things which is bothering the patient and the family. That's pain Number 2, breathlessness. And number 3, the patient is more irritable, not comfortable at all. You have tried administering 4th hourly doses. As we all thought that 4th hourly doses is helpful, but sometimes you might skip the time, or the patient may have the pain or the breathlessness aggravated all of a sudden. Then what is he going to take a step then? So it's important for you to think about it and start on infusion. It saves your time. As a nurses, we are very busy there. Number 2, the drugs will be entered into the body in a continuous manner. It will not stop. It is called as a continuous infusion pump. So when you fix it, do not go for a longer break, like 24 hours or 48 hours. The infusion pump should be given approximately 12 hours to reassess the symptom, whether the patient has been achieved with my management or not. If it is managed, you can go for the next level. If that is not managed, it gives you more information on to increase the doses of regular medications. The nurse's charting on symptom severity and documentation. It plays a major role. There is a symptom which is not under control. You have to start charting on it. So by tomorrow morning, when the doctor comes in, or the senior nurse or whoever it is, they come in, when reassess the symptom, that documentation gives you a lot of information on to see the whole night the patient has suffered a lot with severe pain and breathlessness. That second hourly nurses charting will be more helpful. Even though with the infusion, there is no big change. And then there should be a next level of action of how to deal with that. The care plan preparation and team discussion. So care plan, every patient need to be discussed on. The team discussion, we call it as a pulse meeting. Every morning when we come, we have a small discussion for 15 to 20 minutes about how the patients were the whole night. So they give a little bit of information. Sometimes the housekeeping team come forward and say that, so this patient was asking me this question. So which were not spoken to the health professionals, sometimes to the IAs or the housekeeping team or any kind of volunteers will be, this kind of information will be explored too. So it's important for you to discuss among the patient's care, and also the care plan on what, as a nurse, what is my role for today? As a housekeeping team, what do they have to do? What the family has to do then? It's not about the whole work has to be done only by the nurses. It's not something that the housekeeping team has to do everything because they have been paid for that. Or it's a family role, as because this patient belongs to you and you are supposed to do it. It's not like that. The work will be distributed among the whole team so that it will not be a burden for the nurse nor the caregiver's stress. Sometimes when you are overloaded, the nurses are overloaded, you can't take the step in managing the symptoms. So to relieve your emotions, you should not be troublesome in your work. At the same, sometimes the family will leave the patient all alone. I have an example of a patient who was carried out to the government hospital with the father. He's a patient with the case of buccal mucosa and a huge wound over the right buccal site. This patient was brought up to our hospital early in the morning. By 9 o'clock, when I was visiting the hospital, I have seen him there, and he was sitting under the tree, and he doesn't have any attenders with him. The son left him all alone, and he left out. By the evening, when I just finished my work at 5 o'clock, when I came out, I saw him sitting out there. I asked him, he's in a lot of pain. It seems like that. I just went forward and asked him about, why are you sitting here? You haven't gone up to the hospital even? Did you get the treatment done? So he has his identity card. We call it as an Aadhaar card. All over India, we use it. He has an identity card and his file with him. Nothing more than that. I asked him, where is your family member? He said that my son went out to bring me some breakfast in the morning. He hasn't come yet. I'm waiting for him. So what would be the reason for the son leaving him all alone? And he was brought up to our hospital with all the formalities from the hospital. And he was brought out to the hospice and we was cared well for 2 months. And later on, the son came forward to take him. So taking break for everyone is more important. The son was struggling a lot in taking care of him all the time, round the clock, not the 6 hours or 8 hours, round the clock. And he was troubled. It was more of burden. Caregivers' stress also has to be looked into. To relieve that pressure, this kind of patients who are with a very poor performance, Why can't we take that responsibility and leave the family, rest the family for a while? We know that this patient is going to live not more than a week. The patient's performance with the 20 may not remain for a week even, very less than that. The patients who are with the performance of 60, the surprise question would be, he might live approximately for 6 months. I'm not worrying more about that. The patients who are in end of life, the way you treat them, the way you support the family is very important. So the care plan preparation of my role is to do this. Maybe when I hand over it to my nurse, I request my nurse to do this and this. There are a lot of things, even in the night shift. Okay, sister, please have a look into that. When you have a good care plan early in the morning itself, that gives you a lot of information, and the way you communicate is more brilliant and acceptable for everyone. When you start discussing with the team, everyone have an idea about, okay, this patient is very bad, maybe I may have to go and help them. Sometimes the nurse is busy, the nurse who is taking care of such patients, and maybe the other nurse can come forward and help in communicating with the family, or educating the family, or discussing with the family about the condition of the patient becoming worse. It's important for you. Next slide, please. That's it. I even forgot about my last slide. Okay, I'm up with this. Can we take up some questions?
Thank you, Suju, for the wonderful session.
I have a small video.
Okay.
I'll just share that. So So this patient, we had an anticipatory plan. Like we know that this patient will develop a lot of pain and vomiting, and she'll become bedbound just because of the disease. This is a case of again the right breast with the lung metastasis and bone mets. She developed tenderness over the spine, and she became paraplegic very soon. So there is a plan of action, a good care plan for her before she go back home. So we spoke to the local resources, like 10 kilometers away from her house, there is a small clinic, and there is a medical practitioner with the nurse assisting him. She came forward to help this patient. I just was on a video call explaining or demonstrating about how to do. And when the situation came, she couldn't take any medications orally. She was in a lot of pain, struggled a lot, and slowly the medications are administered through that route. So this did not happen in just in a day. And we have been planning that. We spoke to the local team, and they came forward. They came forward how, earlier itself, I spoke to that local doctor, telling them that we're requesting you to have a look at that patient whenever they need. Most probably now villages, what they do is, when these kind of procedures happen at home and the patient passes away, they feel that just because of administering the medications, my patient passed away. They feel that it is not just because of the disease, nor anything else is involved in that. So you have to be very confidential about what you do. When you have this kind of anticipatory plans, the family will be prepared. See, the patient was not brought up to back to Hyderabad. They live somewhere 8 to 10 hours away from our place, but still we haven't left the patient alone. We looked into the local resources. One day the patient's condition becomes worst, the family was prepared. When the patient in that situation, they called up, and meanwhile they went out to the local doctor and requested the nurse to come and have a look at the patient. And the patient was comfortable till her end of life. And followed by that, these kind of patients were not taken to any kind of private hospitals. Keep it in mind, many such patients, they don't think about the money. When the patient is all right, when the patient is comfortable, they don't like to receive this kind of bad news. The poor prognosis, the condition is becoming worse, the patient's disease is extensive, he couldn't take oral medications, or he cannot take any kind of oral feeds, is becoming bad. This kind of information the family will not receive when the condition is good. So try to have a very good serious illness conversation that makes you censored when the condition becomes more worse. So that kind of documentation was more helpful for them. And this patient was not taken up to the private hospital. We know how the private hospitals are running right now. More commercial, even in end of life, they don't think about admitting the patients. Even though they don't admit, they wanted all the scans and tests to be done. They wanted all the doctors, whoever it is, in all the departments to come and see the patient, even though in end of life. This is all commercial nowadays. So the family need to spend a lot of money, and the death should happen somewhere in the ICU instead of giving a comfortable death. So what did we achieve in that situation then? So palliative care plays a major role. We also run a home care setup. We have 8 vans running right now. 2 looks after the pediatric patients, 6 vans look after the adult patients all over the city of Hyderabad. Among this, last week we had a meeting on how the things are going on. None of the patient was taken up to the private hospital. Few patients were brought to the hospice for a comfort care, and none of the patient was admitted in the private hospital, because we know that if they go up to the hospital, the patient will be put on the ventilator, nor the ICU, and the family will be outside, and there will be a conflict again. No good communication among these kind of teams, and the patient suffers a lot and die one day. We know that death might happen because we are planned, but not the private hospital setup will not be in that way. So have a good assessment, manage well, and share the information to the family. And maybe these anticipatory plans could also help the family in preparing themselves for the patient's end of life. Thank you. Take up other questions, please.
Anybody have any questions regarding this subcutaneous infusion? Please ask him. Swarup, we have a video on subcutaneous infusion. Can we show that?
Go ahead.
Yeah.
Go ahead.
Okay. Thank you. I hope you might have some questions regarding this. Please ask any questions you have. Swarup, we don't have a case presentation today. We can discuss the session and
Okay.
Yeah.
I didn't get the question there. See.
Oh.
We give growth. What is it?
Okay, we can wait sometime. Senior?
Ma'am, can you hear me?
Yeah, yes. If there is any questions in the chat box, please share.
No questions till now. There is a question that if we can share this video. We can't share it now. We do have some copyright issues. These videos are made for NHSRC, so we can't share it now. Sorry, ma'am. No other questions, ma'am.
Yeah, maybe after 2 weeks we can able to we will be able to share it with you all. So the NHSRC is starting uploading videos in their YouTube channel. After that, we can able to share it with you.
Ma'am, there is another question like, sir, when we give growth from Saloni, can you speak? Please speak up.
Sorry, ma'am, can you repeat?
Actually, can you please repeat your question in the chat box?
When we give the growth factor, then we subcutaneous, then we see a swelling in arm. Then how we can infusion so much infusion in such amount?
I'm sorry. Can you repeat the question, please?
Sir, when we give growth factor to the patient, Then subcutaneous, we see in arm, we see a swelling, a little bit swelling in his arm, in the patient arm. Then how we can give such amount of fluid subcutaneous?
Okay, you're talking about the fluids, right?
Yes, sir.
Okay, that's what I'm talking about. So initially there will be a little bit of swelling. That swelling will come down maybe in next 5 minutes or 10 minutes. So only thing is the regulation is more important. If you see lot of swelling, so there is a standard protocol that 1 ml in a minute. But somewhere if you see lot of swelling there, then it has to be regulated again. Only thing is based on the level of swelling, there should be a mild to minimal swelling, not more than that. So when it has to be, the fluid has to be regulated in that way. Even the drugs which are administered through the subcutaneous route also has to be managed in the same way. That's all. There is no standard such protocol. Only thing is, if you see a lot of swelling, the family has to be educated about that. The family has to be taught about there will be a little bit of swelling, which means that it is under the skin and it absorbs well after a period of time. Maybe it may take 5 minutes or 10 minutes for the drug to get absorbed in. So that's not a big deal. Only thing is you have to communicate with them. But about the fluids, it has to be regulated based on the swelling. There should be a minimal swelling, which means that the fluid entering into the underneath the skin is safer. Not the high volumes are being introduced into that. Yeah, and if you find that there is a huge swelling, you have to reduce the speed of the volume which is entering into that. That's all. That's the only thing.
Okay. Thank you, sir. Thank you.
So there is another question like, what is the maximum amount of fluid?
Okay, there is a question. Maximum amount of fluid? Question mark. What is this question? Like, are you talking about the whole day, 24 hours?
Yes, sir, for 24 hours, sir.
Is it? Okay.
Yes, sir.
We have discussed already. 500 to 1000 ml per day is much more enough. That's all. See, one thing, just keep it in mind. We are not going to really rehydrate the patient with that. It is an alternative kind of a treatment to bring the family back to the normal scenario. For example, every patient who comes and get admitted in the hospital asks for IV fluid in general. As the same, the end of life patients also come and they wanted the BP to be checked and to undergo some kind of hydration or IV fluids or whatever. They feel that it is the safest thing and it picks up the to normal level of the patient. So it's important for you to connect it and look for the changes. Unless there is a need, you can't go for that. So there is a maximum, like approximately 1000 ml can be given in 24 hours. Approximately 700 to 1000 ml be administered, not more than that. And look for the change. If really the patient is being benefited with that, you have to go up tomorrow. If there is no benefit, this itself can give you an example to the patient and family that, see, yesterday we have gone for this and there is no big change happening, which means that the patient's general condition is becoming poor and poor day by day. It is not an alternative hydration for him. That's how we have to. So the maximum volume is going to be 700 to 1000 ml per 24 hours. Starts from 500. Yeah.
Swarup, nowadays the study says 1.5 liter
Okay.
per set we can given for
Okay,
24
okay.
hours. If they, yeah,
I
if we
heard
give,
it.
if we want to give more than 1500 ml, we can
Yeah.
choose 2 sites.
Yes.
So
yes.
one site we can give 1.5 liter maximum.
Hmm. Thank you, Shiva.
Okay. So and also normally we use normal saline. Normal saline is the safest solution for using giving subcutaneously. So and the another thing is why we all think about that why subcutaneous infusion we choose for a palliative care patients. We can avoid multiple needle pricks. We all nurses so we know very well for getting intravenous route. So when a patient's in end of life care or after chemotherapy, we are not able to find the intravenous route fluently. So here, if you choose subcutaneous fluids, subcutaneous route, we can avoid multiple pricks. And the another thing is, most of the palliative care medications can be given through subcutaneously. So we can use subcutaneous infusion for giving medications, and our aim is to improve, promote comfort, and improve the quality of life of the patients. So if we are able to give a good symptom relief, definitely we can able to promote comfort, and we can able to improve the quality of life of the patient and the family. So we always think like that. Okay, thank you.
Ma'am, there are
Any
no questions in the chat.
okay, please read.
Ma'am, no more questions.
Okay, no more question. Okay.
And we don't have a case presentation today also.
Yeah, yes. Okay. Swarup, thank you for your wonderful presentation. Anybody have any doubts regarding this? Oh, you can leave. You can leave. Okay. So I hope this presentation is clear to everyone. If you have any doubts, please share it in the WhatsApp group. We will try to answer your questions. And always this subcutaneous infusion is not familiar with you all. I understand that. We all in palliative care settings we prefer this route, and we in Pallium India we have in Pallium India a lot of patients we in our ward we always prefer subcutaneous infusion. When the trainees come for training, they trained how to put subcutaneous needle and how to do the subcutaneous infusions and all. So I hope all of them after trained, after got training, they'll go back and start subcutaneous infusion in their institutions. After that, if they have any doubts, they ask me like that. So what's the maximum fluid can be given to one site, and what are the medications which we can able to give on one site. So here we can give morphine, buscopan, midazolam, and glycopyrrolate. Most of the as I said earlier, most of the palliative care medications we can able to give on subcutaneously. So for example, if you think about the intestinal obstruction patient, we are not able to give anything. So always they'll vomiting, projectile vomiting will be there sometimes. If there is upper intestinal obstruction there, upper GI tract obstruction there, so projectile vomiting will be there. So we need to give some medications. Sometimes we are not able to find the intravenous route. So that time we can give a subcutaneous infusion, continuous. We can give continuous subcutaneous infusion and control their symptoms. So always think like that. And also in end of, as Sarup said earlier, in end of life care patients, the caregivers will might be coming and ask you give one IV fluid. Their loved ones, maybe that person, the father or mother or brother or sister is not eating anything through mouth. So they are more worried about that. They ask to maybe ask you to give one pint of fluid. So then what you will do, what you will do, you always think like that. And also they will ask for please put a right tube, even in the end of life care situation also. So you have to make them understand that what is the advantages and disadvantages. And if they want that continuous, if they frequently ask to put subcutaneous infusion, what you can do is you can do infusion like intravenous fluids. You can do subcutaneous infusion. 1 pint is enough for over continue that over 24 hours. So they will be satisfying for that. So if they, even 1 pint will produce lot of problems. If they have developed any problems, you can tell the that side effects of that intravenous fluids, that or subcutaneous fluids also. If they might develop some side effects after the infusions, you have to educate the caregivers about the importance of the disadvantages of subcutaneous infusion or intravenous the infusions. They will understand well. So after that, we can able to stop the fluids. So always you can think the subcutaneous infusion during the end of at least during the end of life care stage. I think senior, if you don't have any questions, I think we can wind up the session. Can we?
Sure, ma'am. We can wind up the session. There are no more
Okay.
questions in the chat box.
Okay. Thank you all for the participation. Thank you.
Thank you all, especially to Swarup sir for being here with us today. We have shared the feedback link with you. Kindly fill it up. We'll see you on the next session. Bye.